Hi there, I'm Steven Simpson,
Hi, I'm Jamie Kemper.
and we're here to discuss our research findings on extending the therapeutic window of TPA for ischemic strokes.
So what is an ischemic stroke? So your brain needs a constant supply of oxygen and nutrients that is delivered through your blood, through arteries. And in the event of ischemic stroke, those arteries become blocked, typically by a blood clot. And this causes there to be less perfusion to that area of the brain, and that brain becomes ischemic and is no longer able to function. So according to the American Stroke Association, every 4 seconds somebody suffers from a stroke, and every 4 minutes somebody dies from a stroke. And about 87% of those strokes are ischemic strokes. The current gold standard for treatment for ischemic strokes is tissue plasminogen activator, which is otherwise known as TPA. So the current accepted therapeutic window for TPA is 4.5 hours or less from the symptom onset of the stroke. And this is because the sooner that you use the TPA, the sooner that you can break up the clot and the more brain that can be salvaged and the better outcomes that you'll have. Unfortunately, most patients do not meet the requirements to receive the TPA, and this is because they might arrive late to the clinic. They might not know their onset of symptoms, so this could be an elderly patient who might live alone and is found to have their symptoms, or most significantly, it could be the patients who wake up with their stroke symptoms, so their actual last known well time is when they fell asleep the night before, which is typically greater than 4.5 hours. So our meta-analysis, which is in the top column of the chart, they wanted to look to see if extending the therapeutic window for TPA would be cost effective and would result in a net benefit. So they did find that by extending the TPA window to 6 hours, it would potentially result in a net societal benefit of $116 million. And they used a linear cost model to come up with that number. So they only evaluated up to 6 hours, and so this number could not be accurate depending on if the value of TPA and the cost involved increase over time, or if the TPA window gets extended beyond the 6-hour period.
We were excited to find 3 different studies of a randomized controlled trial and a retrospective study that all were testing for similar things of extending the TPA window and all using similar inclusion criteria. So primarily they are all using the same dose of TPA. They were all using the NIH scale and the modified Rankin scale, which tests for functionality, as their reassessment techniques. And they were using the same MRI imaging to declare whether the stroke has been inside or outside of the typical therapeutic window. So they used what's known as DWI and FLAIR mismatch as their criteria. They're both 2 different MRI imaging, where DWI stands for diffusion weighted imaging and FLAIR fluid attenuated inversion recovery. If you look here at our image on the right panel, this bottom right hand pair of MRI images shows a really good where there is no mismatch. You see that the DWI lesion is lit up, and you can also see it faintly in the FLAIR imaging. So this means that this stroke is most likely acute and within the typical therapeutic window. Now, if you go to the other column here, if you follow my cursor, the DWI image still shows the lesion nice and lit up there on the left side, whereas you don't see it as clearly on the FLAIR image. This shows mismatch and that this patient could potentially benefit from TPA outside of the therapeutic window. Going to the Wake Up trial, which was exciting to find because it was known as the first to be testing TPA outside the therapeutic window. They reassessed their patients at 90 days, and they were found to have better functional scores. So they had low scores on the modified Rankin scale, And they also had low scores of on the NIH scale, meaning good neurological outcomes. They did, however, report intracranial hemorrhages versus the placebo group, which was totally expected from the administration of TPA. Below that, we have the MR Witness trial, which again is similar. It was a smaller study, only 80 people, but it was exciting to find because it extended their window up to 24 hours since symptom onset. Again, you see over half of the entire group had good functional scores. They did report 7 deaths from the experimental group, but again, these were expected from the administration of TPA and previous comorbidities, which was their primary finding, was that if you went in and had multiple comorbidities or an extensive medical history, that even after TPA administration, your outcomes would be more detrimental. Our retrospective study, again, very similar to the last two, had good 90-day results of neurological outcomes and functionality, and using the DWI, FLAIR, and as well with 2 other imaging techniques that they say need more studies to prove their efficacy. Jamie?
Yeah, so our final study is our systemic review, and this further supported the results from the other studies that we have looked at so far. So the systemic review looked at several different studies that have looked at the use of neuroimaging to extend the therapeutic window for TPA. So it looked at the Extend trial, the Wake Up trial, the MR Witness trial, and the THAWS trial. And it concluded that the use of these neuroimaging technologies, especially in the population of patients who wake up with stroke symptoms, it is a more efficacious way of using, of finding the timestamp of the stroke versus the last known well time to treat with TPA, and it was associated with overall better outcomes and is an overall better indicator for the use of TPA than previous methods. And more research should be done to further conclude on this topic and to find the best methodology of an indicator for TPA use in treatment of ischemic stroke.
So to recap, we found promising imaging techniques to determine a time of a stroke or its age. And we've proven that TPA can be beneficial to many patients that typically do not fit in the box of the typical window. The adverse effects that were found were not outside of expected for the administration of TPA in these patients.
So although all of this research sounds very promising and it does have the potential to help save a lot of people's lives and also help decrease potential negative outcomes of strokes, there are some potential downfalls or limitations to these research findings. And these research findings would specifically require the facility that the patient goes to, that they have a 24-hour emergency MRI scan available at all time in order to get these results to determine if they are eligible for TPA if they present outside of the normal therapeutic window. So unfortunately, many facilities are not equipped with this type of MRI technology at this time. So this could be a significant limitation to the results of this research. Also, there still needs to be more research done in order to further validate the findings of the research studies that we have reviewed today and the other ones that we have not reviewed. And there are several studies that are going on right now that further look at the use of neuroimaging as an indicator for TPA use in ischemic stroke sufferers. And those studies include Timeless, Tempo 2, and Twist. And we are anxious to find out what the results of those are and to see if they further support this topic. Thank you.
Thank you.